thank you for joining us this morning for April's edition of Health Bytes with Region 3. I am beyond pleased to welcome this month's speakers, Jennifer E. Hubbard and Elle Markman. Jenny Hubbard currently serves as the lead behavioral health specialist for the Denver market with One Medical Seniors. She's a licensed clinical social worker and licensed addictions counselor who has spent the last 10 years working in healthcare and has a passion for improving behavioral health access within the primary care setting, improving health outcomes, and enhancing the partnership between behavioral and medical professionals to better serve patient needs. Jenny also serves as a field instructor for graduate social work students and teaches for the University of Denver Graduate School of Social Work as a member of their adjunct faculty. We also have with us this morning Dr. Elle Markman, who is the National Director of Integrated Behavioral Health at One Medical, a technology-enabled primary care provider that joined forces with value-based care innovator Iora Health to transform healthcare for patients across the lifespan. Dr. Markman trained and worked in a variety of integrated primary and specialty medical care settings prior to joining Iora as a behavioral health specialist in 2019. Last year, she transitioned to One Medical's Medicare Population Health Program, where she works to drive integrated behavioral health performance and strategic impact on population health, cost of care, quality, and health equity. In today's Health Bytes, our speakers will give a presentation on improving health outcomes, utilizing integrated behavioral health and value-based payment modeling to transform healthcare with older adults. Thank you for being our guest speakers this morning, and I'll turn everything over to y'all.
All right, thank you so much, Bailey. I'm Jenny Hubbard. Let me pull up the slide deck here and we can get going. All righty. So again, thank you so much for having myself and Dr. Markman today. We're really grateful for the opportunity to be this month's presenters for Health Bytes, and we're excited to review how we can improve health outcomes in primary care for seniors by both integrating behavioral health into the primary care setting and implementing transformative payment modeling practices like value-based care. A couple of disclosures. Both Dr. Elle Markman and myself work for One Medical Senior Health, which is a value-based primary care practice and healthcare subsidiary of Amazon that practices integrated behavioral health. One Medical has received no financial compensation for this presentation. A brief overview of what we aim to cover with you today. We'll provide an introduction to integrated behavioral health and holistic primary care, an overview of value-based care and payment reform, and then have a discussion of senior care that uses both integrated behavioral health and value-based care in with seniors. And then we'll leave some time at the end to answer whatever questions that you may have for us. We're very happy to entertain any thoughts that may arise. So before we get into concepts like payment reform and value-based care and integrated behavioral health, we'd like to start by introducing a concept known as the triple aim. And that's a concept developed by the Institute for Healthcare Improvement, IHI, that describes the goals of healthcare for individuals and a society, or the society in America. So the first aim is improving patient experience of care that includes quality and satisfaction. Now, up until the introduction of the triple aim in 2007, if you asked many in the field what the goals of healthcare were, they may have referenced the patient experience, in particular, the 6 domains of healthcare quality, as outlined by the Institute of Medicine. And those 6 dimensions are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Now, this is still agreed to be the aim of healthcare in the individual experience of care, yet the triple aim expanded the goals of healthcare beyond just the individual experience. Enter in the second aim, which posited that healthcare should also strive to improve the health of populations. Now, population health is defined as health outcomes of a group of individuals. And that can be across geography, as in certain communities, or a group of employees, ethnic groups, prisons, or any defined group of people. And then lastly, the IHI suggested that we should improve patient experience and health of populations while reducing healthcare costs per capita. And so this became known as the triple aim, and it was widely adopted as an approach to optimizing health system performance, proposing that institutions simultaneously should pursue those three dimensions of performance: improvement of patient experience, improved population health, and reduction of healthcare costs. And then in 2014, industry professionals noted the widespread burnout and dissatisfaction of physicians and others in the healthcare workforce. Burnout is associated with lower patient satisfaction, reduced healthcare outcomes, and it may even increase costs, which jeopardizes each goal of the triple aim. Therefore, it was asserted that the fourth aim, improving the work life of healthcare professionals, must be achieved in order to realize better care, better health, and lower costs. And then, very recently, the COVID-19 pandemic cast a spotlight on the lack of health equity in the United States and around the world. The pandemic forced healthcare leaders and policy makers to grapple with the great health inequities in our society currently. Thus, the pursuit of advancing health equity was elevated to the fifth aim for healthcare improvement. And so there we have it. We now have what's known as the quintuple aim. It's essentially a compass that tells us what success looks like in healthcare and where our true north is. So for today, we'd like to share with you an approach to primary care which seeks to achieve these goals of the quintuple aim, as we not only aim to improve healthcare, but do our part to transform it. And to start, we're going to do so by reviewing one of the aims of healthcare, cost reduction, and how reforming payment models in healthcare is suggested as a critical element to achieving the quintuple aim. So this probably is a surprise to nobody here, but healthcare costs in the United States have been rising for decades, and they're expected to keep increasing. The United States has one of the highest costs of healthcare in the world, and according to a study by the Pearson Center on Healthcare and the Kaiser Family Foundation, in 2021, the United States healthcare spending reached $4.3 trillion. And that averages to about $12,900 per person. Now, relative to the size of the economy, healthcare costs have increased over the past several decades from 5% of the GDP in 1960 to 18% in 2021. But why are costs rising so much? Well, generally speaking, healthcare spending can be thought of as an equation of price, how much do we charge for healthcare services, and utilization, the amount of services used. Now, there are several underlying factors that can increase both the price of services and service utilization, which then increase the overall spending. A 2017 JAMA article investigated 5 key factors associated with those cost increases. 1, population growth. 2, population aging. Those that are 65 and better tend to spend more on healthcare than any other demographic. 3, disease prevalence or incidence. 4, service price and intensity. The cost of healthcare services typically grow faster than the cost of other goods and services in the economy. And then lastly, medical service utilization. Now, all of the above is true, and some analysts say that the debate on why healthcare costs are rising is ignoring one of the leading causes, which is the very way healthcare providers are paid and potential perverse incentives within the dominant payment models. So, how is healthcare funded? Well, the payment model known as fee-for-service has been the dominant payment mode for physicians in the United States. The model has been with us since the 1930s in the United States and has been with us ever since. In 2010, it represented over 90% of primary care practice revenue. Now, other payment models have since entered into the mix, and fee-for-service remains the most common practice. Now, in this model, doctors charge their patients a fee for each individual service provided. This means that insurance companies or government agencies are billed for every test, procedure, and treatment rendered whenever a patient visits the doctor, has a consultation, or is hospitalized. And if there's no insurance, then the individual will pay out of pocket for that service. The payment structure is relatively straightforward, and this allows doctors to earn a living by providing medical care. And there's a handful of advantages to this model. Because the model is so widespread, it can offer patients a lot of flexibility when they need care. If their doctor is unable to see them for any reason, they can schedule with another doctor or go to a different practice, because so many people use this model of payment. Patients also have the freedom to choose services that they receive and the provider they see. And some would argue that there's even transparency with the model, as the patient may be able to see how much each service costs and make decisions based on healthcare expense and need. However, I'm not exactly sure how wide practice that is. And while the payment model has been the dominant approach for decades, it has come under increased scrutiny in recent years due to concerns about rising healthcare costs, overutilization of services, and fragmentation of care. And what's underpinning this argument? Well, unfortunately, the model may be based on a perverse incentive, or an incentive that has unintended and undesirable results that is contrary to the intention of the designers. The model is based on quantity of services. It's right in the name, fee for service. There's a reward for more services, not necessarily better services. Most fee-for-service models are paid simply for each service, regardless of the results of the services. Now, this can lead to overutilization of healthcare services, including unnecessary tests, procedures, and treatments. Increased quantity of services and incentive to recommend more expensive care can be associated with overall increase in healthcare costs. Because the fee-for-service model rewards providers for treating illnesses and conditions rather than preventing them, it can disincentivize providers from investing their time and resources in preventative care measures, such as health education and screening programs. It also does not directly reward key primary care functions, especially coordination or comprehensive care of patients with multiple chronic conditions. In many fee-for-service models, there's little attention on the quality of care provided, as economic incentive is quantity. And this means there isn't much incentive to think through if services are effective or even necessary. And lastly, healthcare professionals are often frustrated by a mode of practice which relies on them to generate as many brief patient encounters as possible. A 2010 Journal of Internal Medicine article read, "Across the globe, doctors are miserable because they feel like hamsters on a treadmill. They must run faster and faster just to stand still. The result of the wheel going faster is not only a reduction in quality of care, but also a reduction in professional satisfaction and an increase in burnout amongst physicians." And so many healthcare systems and insurance companies are exploring alternative payment models, like value-based care, which are intended to incentivize providers to focus on quality of care and better outcomes. So what is value-based care then? Well, it's a form of reimbursement that ties payments for care to the quality of care provided and rewards providers for both efficiency and effectiveness. It's an alternative payment modeling to the fee-for-service model. Now, quality can be defined in many ways to determine the overall health of a patient population. So, for example, it could include the implementation of specific preventative measures like universal depression screens, and that can help then detect and potentially treat otherwise undetected mood disorders. It can include reviews of health markers to ensure they're in range, like weight, blood pressure, A1C. It may even include reporting on reduction in things like hospital admissions. Overall, it focuses on improvement of preventative care. So value-based care models are also driven by data because providers must report to their payers on specific health metrics and demonstrate improvement in their patients' health. Providers may have to track and report on hospital readmissions, adverse events, population health, patient engagement, and much more. Now, there are several different forms of value-based care payment models, and there are some agencies that might even blend these payment models with fee-for-service, or even blend a certain type of value-based care with another type of value-based care. And we're not going to go into extreme detail about each specific type of program and plan, but I'll highlight a couple of here. So first off is an accountable care organization, or ACO, and that's comprised almost of any combination of physician groups, practices, networks, hospitals, and other facilities that agree to share responsibility for the quality, cost, and coordination of care for a defined patient population. And then there's bundled payments, in which case providers are paid for the care of a patient's medical condition across the entire care cycle. That is, all services, procedures, tests, drugs, and devices used to treat a patient, say with heart failure or an arthritic hip that needs replacement or diabetes. Patients pay a single price for the entire package that meets their needs. So you can compare it to other forms of purchasing. For example, buying a car. Consumers don't buy a motor from one supplier and then the brakes from another and so on, but they buy the complete product from a single entity. And that's the same type of concept. Then we have the patient-centered medical home, or PCMH, and that's a care delivery model that coordinates patient care through the primary care physician. So in PCMH, it's designed to provide patients with a centralized care setting, i.e. primary care, that manages the different needs of a patient. And then there's capitation with shared risk. So in this model, a providing agency or physician is given a lump sum of money to pay for a patient's care for the entire year. The patient can have as many visits as they need instead of just a certain number of visits. However, if the patient seeks outside medical care or needs additional care, the provider then assumes risks, and that provider and agency would then pay for that outside care, like a hospitalization, out of that lump sum that they were given. So it's designed to reward increased quality of physician care provided by incentivizing preventative care and keeping patients healthy, which can then reduce unnecessary expenses or even prevent things like hospitalizations. Now, there have been quite a bit of studies that point to some real potential benefits of having a value-based care model. So first off, lower doctor panel size may lead to improved access and lower hospitalization rates. As you can see here in this study, a standard fee-for-service model may have a provider panel size of 2,500 patients compared to value-based, which has about 800. Next, value-based primary care is associated with longer visits with a provider. So for example, I'll refer to our model at One Medical Seniors. A typical provider time in the visit is about 30 minutes, but that's compared to 14.5 minutes for the average primary care doctor. Next, there is no fee-for-service structure. And so patient questions can be answered through brief phone calls, text messages, etc. Now, in the fee-for-service model, there is a focus on always being able to bill for your time. So you might need a patient visit outside of these brief touch points. And having the ability to have these brief touches afforded by value-based care increases efficiency in delivery of care, since there's no feeling being beholden to that fee structure. In addition, there's a reduced economic penalty for no-shows. And especially in capitation payment-based care that can invest in infrastructure upfront by offering things like wraparound care and preventative services. In one study found that compared to fee-for-service, value-based care was associated with improvements in all eight metrics that they measured, and that included lower rates of inpatient admissions and lowered 30-day readmission rates. So note this last one, it had a very large sample size of over 320,000 participants. So that's value-based care, where it is current state, even past state, but where is it going and what does the trajectory look like? Well, the trajectory of value-based care is one of rapid growth. By 2025, Blue Cross Blue Shield, one of the nation's largest private insurance agencies, has a goal to have 50% of total payments be value-based. Private capital inflows to value-based care companies increased fourfold from 2019 to 2021. And in 2022, the American Association of Family Practitioners stated that 49% of surveyed practices are receiving some type of value-based payment, and another 18% are planning to do so. Now, in its first year of direct contract programming, which is a certain type of value-based care programming that started, I believe it was 2018 or 2019, 58 entities, including us at One Medical, were estimated to save Medicare about $70 million and saved insurance companies an estimated $48 million. So in other words, value-based care is here to stay, and it's growing incredibly rapidly. And now I'm going to pass it to my colleague, Dr. Markman.
Thanks, Jenny. So now we thought it would be helpful to potentially dive into a bit of an overview of integrated behavioral health within value-based care, and particularly thinking about one specific model of integrated behavioral health that our program at One Medical is based from, called primary care behavioral health. We're going to go to the next slide. So just to dive a little bit deeper into primary care, the kind of first function of that combined integrated concept, we view primary care as kind of the cornerstone for building a strong healthcare system. And you could extend that further and say it's the cornerstone for building a strong population, right? It is typically the entry point and the bridge for most people between the community that they live and work in and the healthcare system. And it's also where we see the greatest intersection between medicine and public health because of this triple aim that Jenny spoke about. These shared aims to transform healthcare, recognizing the challenges we face right now, to reduce the healthcare costs, to reduce some of these healthcare disparities, and to improve population health outcomes overall. So this is where the greatest opportunity lies, to really make that impact. But in order to be set up for success, there are four kind of core functions of primary care that need to be in place. So the first is this idea of what's called first contact, which really just means access, right? It's this idea that a patient, no matter where a potential patient, member of the population, wherever they live, has access to initiate care in primary care whenever that entry point arises, hopefully earlier than later. And then that they have continual access whenever they need it, as often as they need it, to their primary care physician. The second piece is comprehensiveness, kind of with this caveat of like what's in scope. So this idea that within the context of primary care, we can prevent, treat, and provide rehabilitation to the extent that it's appropriate without a kind of that step higher into specialist care, to avoid some of that, what we consider unnecessary or avoidable specialist care or hospital admissions. And what's happened more recently, which is exciting for us, is that this idea of comprehensiveness has extended to both the body, which is traditional, we think of the physical health, medical health, but also to the mind, recognizing finally that the mind and the body are actually connected. And when we talk about comprehensive medical care, probably that should be inclusive of both of those terms, in addition to social health, which is we'll talk a little bit about today, but I think is the next wave of how we're thinking about comprehensive primary care. And then thirdly, this idea of coordination. So this idea that the primary care provider, the primary care team is sort of the quarterback of a patient's care beyond, within, and then beyond the walls of the primary care facility. So you heard the term medical care home. We think of it as very much like the home base for a patient, not to say they will never need a special care, will never need to go into the hospital, but this idea that we as the primary care provider kind of have oversight and have the ability to kind of help the patient navigate what is in reality a very complicated system to navigate. And then finally, this idea of continuity of care, which is very unique to primary care. It's this idea that the relationship between the PCP and the primary care team and the patient is longitudinal in nature. And so we have, I think, both the privilege, but also the challenge of building relationships and building trust and then maintaining that over time throughout the course of that relationship. Next slide. So then the question of like, why, where does integrated behavioral health come in? Why integrate behavioral health into primary care. So just to back up a little bit and kind of set the stage for the problem, roughly 25% of the population is estimated to have a mental health condition of some kind to some degree at some point in their life. Now, I think with as inclusive as that is, that's likely an underestimate, particularly probably if you were to have some research done in the most recent years in the era of COVID. I think that number has skyrocketed probably. But using this number from what we know already, less than half of that group actually ever receives mental health treatment of any kind. And then of those who actually do, about 50% of those people, their care is limited to the primary care space. So what that tells us is that there's a really big opportunity to leverage the reality that patients are in fact using primary care as their entry point into care. And that in some cases, that's where kind of the buck stops, where they don't then pursue mental health care beyond then to say, okay, let's see what we can actually provide in a meaningful and effective way within the confines of primary care. And in some cases, be that bridge more effectively to specialized mental health care. So along that vein, there's 4 kind of buckets we think of as far as like the big opportunities and the big whys behind integrated behavioral health and primary care. One is we recognize that all of the kind of numbers that I just said above represent that there is a major mental health crisis in this country, and there is highly inadequate mental health care landscape in terms of network access. So in large part, one of the reasons that only 50% seek mental health care outside of primary care is that in some cases it just doesn't exist, particularly in certain areas in the country where there is not that high density of specialist providers. And also, even if it exists, it's incredibly hard to get connected to. There's very long wait times. In many cases, there's not a lot of providers taking any kind of insurance, which just simply isn't affordable for the vast majority of our country. And so to have primary care include behavioral health within it as part of that comprehensive offering, it removes a lot of those barriers. Transportation, oftentimes these community mental health or community primary care clinics are actually rooted in the community and are much more accessible to the patient than the nearest specialist might be. Geography, same thing, and network inadequacy, and then cost. Again, it's particularly when we're thinking about value-based care and a capitated payment model, the behavioral health care is wrapped up within the cost of the primary care as opposed to an additional cost that may or may not be at all covered by insurance. It also really destigmatizes mental health care, which has been for so long stigmatized in this country, because it normalizes it as just a routine part of primary care that everybody has access to. And I think just to call out, it's not an accident that we're kind of using 2 different terms, mental health and behavioral health. I think wrapped up into all of this is there's been a very real and very intentional rebranding of what has traditionally been mental health because of all this stigma. And so when we talk about behavioral health and integrated behavioral health, I think that is also representative of this attempt to normalize and restigmatize. And that is very intentionally part of the PCBH model. And in the second bucket, we talk about improving medical health outcomes, right? So in the time that integrated behavioral health has been around, we have set precedent that actually we have a meaningful impact not only on patients' behavioral health outcomes, but their medical health outcomes. And if we look at kind of the data, we see that over half, in some cases, nearly 70% of primary care visits relate in some capacity to psychosocial concerns, whether they're presenting to their PCP specifically for a psychosocial concern or the contextual factors related to the medical concern are so heavily influencing or being influenced by the medical condition that it's just not avoidable to discuss it. And so it would follow that to actually be able to address the psychosocial concerns in a meaningful way and in an efficient, effective way is actually going to lead to a more substantial outcome. And then along that same vein, if you think about the realities of chronic medical conditions, they require typically a lot of change management, a lot of behavior change, a lot of coping with life kind of realities and adjustments that PCPs often, and this is changing now, but traditionally and often still don't really have the training and certainly the bandwidth or the time to navigate with patients in a really meaningful and helpful way. And here we have behavioral health providers who have that specialized training to do exactly that. So there's this real opportunity to leverage that within the PCP kind of space as a partner. And then also we've been shown, as Jenny mentioned, to reduce healthcare costs, and that's both for Part A and Part B. So hospital admissions, ER visits, and just general outpatient specialist care. And this makes sense because what we found is that chronic medical and comorbid behavioral health conditions tend to cost 2 to 3 times more than chronic medical conditions alone, and are associated with more hospital unnecessary and again avoidable hospitalizations and ER visits. So again, it tracks that if we're talking about behavioral health as part of the treatment plan, we're going to be much more effective at preventing some of these hospitalizations and unnecessary specialist visits. And that's within behavioral health, but also medical specialists. And then finally, also, like Jenny mentioned, PCPs, patients, caregivers really see the benefit, and their experience tends to be better when they have a member of the team who is acknowledging and normalizing this piece of their life and their clinical picture and is able to address that in a meaningful way as a partner to the PCP. All right, next. So when we think about like, what does PCBH actually look like? What does a PCBH provider actually do? We think of this acronym called GATHER. So the first piece of it is that we are generalists. So essentially the idea is that we are able to come into any situation and triage and treat any concern that might come up, any age. And a little caveat to the age, obviously we're talking largely about geriatric care. So that's not always the case, but in a general primary care behavioral health setting, you might be kind of coming in to see a 5-year-old with behavioral challenges, or you might have a 95-year-old who needs to address end-of-life issues. And not that we need to be specialists in every single one of these areas, very much sort of a consultation liaison or ER model of jack of all trades, being able to kind of take everything on and really triage and figure out how we can help in that moment. We're also accessible, and that's both to PCPs and care team members through curbside consultations, but also that we have same day, next day access for patients who are already there. They don't have to make another trip. And again, so it kind of presents as we're in a shared space together. And so we kind of, the way our schedules are built is that we kind of go back and forth between scheduled visits and this, what we call team access, which could be any of those other things I mentioned. Team-based is the third one. So again, it's this idea that we are embedded core members of the care team. We participate in any and all discussions about patient care. We huddle with the team, we round with the team. And really part of this is to normalize and kind of inject the behavioral health expertise and perspective in all of these conversations, whether or not we're directly interacting with the patient. High productivity for us at One Medical, the way we think of this is less so about how many patients we see and more so about wearing a lot of hats. So thinking creatively about whether we're in the room with a patient and we're accessible or whether we're not, how can we again inject that behavioral health expertise and perspective? So that typically for us means a lot of care management, a lot of teaching and training, which we'll talk about with PCPs, with our health coaches, and then population health activities. We do chart scrubbing, we do pre-visit planning for the next day, identifying our highest risk, highest complexity patients we want to be able to meet with the next day, so we're prepared. So that's really what we're looking at with the productivity piece. Going into what I mentioned with education, one of the biggest, I think, things about the One Medical model and what makes it unique is how much we emphasize this education piece. And we'll get a little bit more into the why behind that. But an important hat that we wear is as an educator, both in terms of the traditional sense of like providing psychoeducation or medical education for patients, but also that's our role for the care team. And then finally, this idea of routine goes again into wanting to destigmatize and normalize who we are, what we bring to the table, and that we are a core part of healthcare. And the more that we can be present on site in these conversations with our care team members, or popping our head in to patients just to say hi and introduce ourselves before anything even comes up as a problem, really works to kind of create the normalization in the routine. All right, next. So you might be asking yourself, okay, but how is this different? And in what ways is this different from your traditional kind of outpatient specialist mental health care? So I've already talked about some of these, but to highlight a few for you. One is, because of the emphasis on access, our visits tend to be much more brief than the traditional 50-minute session. Typically 15 to 30 minutes, although of course there are times where we might go an hour long. And the reason for that is, if we have a lot of brief sessions interjected, we keep our access open and our availability open for other visits, but also for all those other activities I mentioned. Another big one is that, as opposed to being seen in a separate office where care is very much siloed as this is your mental health or your behavioral health space and time, we share the same rooms. We often see patients in exam rooms. We share the same patient chart and same documentation style. We share the same care plans with the PCPs. All of it is truly and deeply integrated. And then another big difference I want to highlight is that traditional mental health treatment plans tend to focus on resolution of mental health symptoms or mental health diagnosis. In contrast, our treatment tends to focus more on solutions and functional outcomes. And now, that said, there's also this kind of dual focus on both your kind of bread and butter traditional behavioral health conditions, anxiety, depression, but also equal focus on chronic medical conditions, uncontrolled diabetes, uncontrolled hypertension, chronic pain. So we'll get a little bit more into that as well. Go on to the next slide. So now, getting in a little bit to what does this look like specifically at One Medical, and a little bit more broadly than that, specifically in care of older adults. So just a quick look at some of the specific impact and how it might differ between traditional or more broad-based primary care versus care with older adults. Just a little bit of background. One of our key performance indicators in integrated behavioral health is something called penetration rate, which is a very poorly named term that really is looking at what percent of PCP engaged patients, so patients who are coming in to see their PCP or having some kind of a touch point, also has a touch point with the BHS, or behavioral health specialist or consultant, that same year. So typically, on average, where we're falling in integrated behavioral health more broadly is around like a 12% mark. So about 12% of the PCP's panel is also seeing the BHS that year. With our data in particular, and on the senior health side in One Medical, our penetration rate is closer generally to about 30%. So why is that? About almost 3 times as high. Overall, it's this much higher acuity, higher complexity, and higher cost patient population, as Jenny was talking about before. To break that down a little bit further, what that actually means is that older adults have more chronic medical conditions, particularly like our most common and highest cost, chronic pain is a big one. And then in terms of most common, obviously, and most unique to this population, cognitive impairment and dementia are very unique to this population and are very, very high on our list as behavioral health specialists of where we can make a meaningful impact. So to give you a sense of, in 2022, our program had about 42% of our visits that addressed at least one chronic medical condition. Now, that might mean we also addressed a mental health condition, but we meaningfully also addressed or attended to diabetes or chronic pain, which is pretty significant, and really much more so. Typically, we see a high priority or high proportion of these visits in traditional settings being much more focused on depression and anxiety and adjustment. Secondly, there's just much more social determinants, insecurities in the older adult population. So the biggest one we see from a sample that we've been piloting around SEOH screening, about almost 30% of the patients screened identified as socially isolated and or lonely. Obviously, these are two different constructs. It can be both, but you can certainly be socially isolated, living alone, and not feel lonely. And you can be living in a house with many people, not isolated at all, and feeling lonely. So we do recognize them as two different constructs, but together they represent the highest portion of social insecurity in this population. And that's consistent in the population more broadly. And you can imagine there's also transportation insecurities elevated in this population, housing, food insecurity. All of that tends to be much more prevalent in a Medicare older adult population. Not to mention, we have a very high proportion of dual eligible Medicare, Medicaid patients where this is particularly elevated. And because of that, certainly there's just much more opportunity for a behavioral health provider to get involved and help navigate the system, get connected to resources, and just more complexity around conversations about medication adherence in the context of financial insecurity and all of these other challenges. And then thirdly, just to call out that again, by nature of the fact these are older adults, we're brought in for a lot of end of life issues, a lot of advanced care conversations, and that's just something that is innately unique to this population. All right, next slide. So the question is that, as Jenny mentioned, this is a growing population, not just for One Medical, but in the United States and in the world. And so there's this question around how do we continue to scale sustainably and effectively for this growing population? And so that's one of the reasons that our integrated behavioral health program at One Medical, but I think more broadly as a trend in the country, integrated behavioral health is growing to be considered a population health program in addition to a clinical program. It's this idea that we, like I mentioned before, we need to be thinking really strategically about how we are going to be able to continue to deliver meaningful intervention and meaningful integrated behavioral health informed care to all of our patients, but particularly the top of the pyramid in terms of complexity and cost as that top of the pyramid grows. And so one of the ways that we think about doing that is through this educator role. This idea of partnering with a role that more broadly is being called the care enhancer, but at One Medical, we call the health coach, as a core part of our integrated behavioral health program. So to go to the next slide, I can give you a visual idea of why this matters and why this is so important. So one behavioral health specialist or behavioral health consultant with another program might cover 1, 2, or even 3 clinics, right? Which means they might work with 3, 6, or even 9 or more PCPs. And each of these PCPs might work with 2 or 3 health coaches. So when we think about trying to reach every single one of these patients, let's say it's a 6,000 patient panel. But as we grow, we think about a 600,000 patient panel or a 6 million patient panel. That becomes much more feasible to reach all of those patients when we think about doing so via this health coach who has more direct impact on each of our patients and leaves our kind of bandwidth available for that top of the pyramid, highest complexity, highest cost patients. So if we go to the next slide, this really raises the question for our future directions of how do we scale? And as I mentioned, a lot of the conversation tends to be around educating and empowering non-licensed clinical team members, such as these care enhancers or these health coaches, with things like patient-centered communication skills, brief action planning, or SMART goal setting. How to respond to a patient or how to know when a warm handoff would be helpful, how to talk to a patient about what a BHS is and start that process of normalizing. Hey, I think that it would be really helpful for you to address your sleep. We together have already gone through some of the basics of sleep hygiene, which my BHS helped me to learn, but we're hitting some walls here. So I'd like to connect you to the behavioral health specialist who specializes specifically in sleep or in insomnia or in diabetes, depression. Secondly, I think one of the big future directions we face is that we need to still iron out how we measure impact. So as we kind of went through at the beginning, there's certainly some precedent already set about cost savings, but we still have a lot to figure out. And the main guiding questions that we have for ourselves are we successfully doing what we're setting out to do? Are we connecting patients at the top of the pyramid with us? Are we prioritizing? Are we introducing patients to behavioral health? Are we destigmatizing behavioral health? All of those things. The second question is, are we doing it in a way that is equitable, that's promoting health equity? Are we reaching, again, the top of the pyramid in a different way than folks who have more resources or more abilities to kind of navigate the system themselves? Are we attributing resources appropriately? And then finally, is it having the anticipated impact on patient outcomes and cost of care that we think it is, that we anticipate it is, based on what just simply makes sense and what the preliminary evidence has showed? And then the final kind of guiding question we have is, how do we continue to innovate? How can we take what we're learning and improve upon it? And one of the big pieces here is the striving for health equity. It's recognizing very real existing racial disparities and trying to tackle those head on. It's addressing the social determinants of health as another key piece of primary care, right? We talked about the brain and the body being connected, and now we're figuring out, hey, social context actually matters just as much. So how are we actively addressing those social determinants? And again, for this population, first and foremost, social isolation and loneliness, this population that we refer to as solo seniors, folks who are either living alone and really maybe shouldn't be and don't have those resources that they need, or might be living in a house full of 10 people and still are not getting the support that they need. It might not be the best scenario for them. And then a very real barrier for us has been around technology, how to leverage technology, how to leverage virtual care. Again, as Jenny mentioned, without the confines of like, they need to be an office visit, how can we think creatively about doing virtual visits? How can we think creatively about using text and phone, while being mindful that this is a population that might not have access or literacy in technology, and needing to be sensitive to that, needing to be creative about it. And then finally, how do we build new tools that actually support and improve upon the work, make it user-friendly, both for the care teams, but also for the patients? So obviously I could probably talk for a whole hour about all the future directions, but those are the high level, the main ones that kind of guide us day to day. And then finally, coming to the conclusion, we want to kind of acknowledge that we're here today to talk to all of you. And Jenny and I have thought a lot about, like, how does this matter? How can you take this and kind of guide the work you do, or think about it in the work that you do? And we had a couple ideas, but we would love to turn it over to you all to ask the question or share any thoughts about how this resonates, and any other ideas that come to mind or challenges that come to mind. But in general, what we're thinking is just to have you all as champions of integrated behavioral health. Again, if this feels like it makes sense and resonates, as opportunities arise for you in research and practice and other arenas, spreading the word and raising awareness that we are an integral part of the mission to transform healthcare. We share in this aim together with medicine and public health. And to think of us when you're thinking of solutions or solving problems for any of these areas that we kind of can loop into and address. So the mental health crisis more broadly, the PCP and caregiver burnout realities of the healthcare today, particularly in senior health, or care of older adults, rising healthcare costs, anything pertaining to, again, this national healthcare debt crisis, and recognizing these perverse incentives of the fee-for-service model and trying to think creatively about new solutions. Health disparities is kind of part of the movement to try to reduce these disparities and create a more equitable healthcare culture and culture overall. And also just the challenges in geriatric care that are very real, and trying to solve for those, or find the best way to bring high quality, cost-saving care to the most complex, the most costly growing population in our country. So I will leave it at that and just say thank you again for having us. And we really appreciate being here and having the opportunity to share with all of you a little bit about what we do. And we're happy to take any questions or hear any thoughts or ideas.
Thank y'all so much. I do want to acknowledge that there was we have just a few minutes for questions. There was a question earlier in your presentation put in the chat. It says, I'm new in my job as a behavioral health counselor in a primary care setting. We're looking at how to set up the workflow. What are your recommendations?
It's a great question.
Yeah, it is. I think there's a lot of things to consider for that one. There's a saying in integrated care that if you've seen one model of integrated care, you have seen one model of integrated care. And so there's different things to consider, like what type of practice are you really wanting to establish? Are you wanting to have like a huge impact and penetration rate that like Elle talked about? Or are you looking to do what can be referred to as more of like co-location and maybe act as like a therapist that's on staff? How many providers do you have in ratio to being a behavioral health consultant? What's your patient population? What are the biggest needs of that population? I would say if you're looking to be more on the further end of the integrated spectrum, you can think of it more of as a spectrum of like kind of siloed mental health practices. That's kind of like the specialty mental health, all the way to fully integrated, where you're just seen as a member of the care team. You may want to focus on how you can build time in the mornings to start the day with reviewing patients with the providers and care team of who's coming in, doing your chart scrubs of what are identified needs. Was this person recently hospitalized? Oh, it looks like this person has a diagnosis of anxiety and COPD. Those two things comorbid together can certainly exacerbate one another. And so where might you be able to pop in, introduce yourself, and do some of those brief touch points? And then if you're really, again, wanting to be aligned in that further integrated model, you might think of structuring your day that does protect some time for those warm handoffs and access. It can be a little bit of a trap if you're scheduling patients to get scheduled back to back to back to back. And then at that point, you're removed from having access from patients that are right there when they come into clinic. And, I always say it's really nice to strike while the iron is hot versus doing a call later, or being able to consult with the primary care team. So maybe even think about considering certain types of blocks so you have that availability if that is what you're aiming for in your form of integrated care within your practice.
To add, if you aren't quite sure, like where with the level of integration or what's actually possible, there's a real opportunity at the very beginning of coming into a space to just do a lot of learning, to learn about the existing patient population, the existing PCP panel, what kinds of challenges are patients coming in with that are not currently being addressed or are not being addressed effectively. And then there's a lot of salesmanship that goes along with starting a new integrated behavioral health program, right? And you have a strong foot to put in the door if you know what those pain points are and you know what those real opportunities are. And also that if you know what the current workflow is and how you can more seamlessly fit into the existing workflow rather than trying to promote a major change, like making a referral to you or a handoff to you the easy option for the PCP. And you'll have a much better idea of that when you sit and observe and learn for a while, a few weeks maybe. Good question.
Wonderful. We do have somebody requesting a copy of the slides. Yes, and we will drop a link to download the slides in the chat here in just a moment. So thank y'all very much. Unfortunately, that is all the time we have for questions. If anyone has any additional questions, feel free to email us, and we will make sure that Dr. Markman or Jenny get a hold of those and can answer those for you. So I just want to say thank you so much for everyone who joined us today, and a big special thanks to Elle and to Jenny for sharing their expertise with us. This was a really wonderful presentation and overview of the important work that they do. We look forward to seeing you all at our next Health Bytes, which normally we would say is next month, but is not. In May, we are taking a Health Bytes break. So we will be back with Health Bytes in June of this year. So thanks everyone for being here. Thank you, Elle and Jenny, and we appreciate you all.
Thank you again.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.